So, welcome to PNR204. This is exam 3 review. It's amazing, exam 3 already. So, this is week 6 through 8. So, your exam is next week 9, and it covers chapters 25 through 32. So let's talk a little bit about respiratory. Well, we think of respiratory, it's your lungs, all your oral pharynx, everything that's in that area. So terminology, you'll always have definition, and there are many questions directly from that definition. So atelectasis is when the alveoli, which is the base of the lung, they're held open, it gets full of mucus, and they collapse. We see that usually post-op with not a lot of cough, deep breathing. Coryza is just a common cold. It is allergies, no fever, sneezy, itchy, that's part of it. Stridor is when you have some sort of airway problem. Usually this is your croup, and that's where you can't get air in. So it's high-pitched respiratory sound when it's going inspiration. So it's trying to get the air in. That's stridor, okay? Wheezing is the opposite, the end. That's expiratory at the end. So surfactant is what the body produces from itself as an infant intrautero, and usually about 24 weeks it starts. They say at 34 weeks the infant has enough and they can be born, their lungs will be okay. And it keeps the lungs open after they're born. It holds it open. It's like that glue, that cement that holds it so we can exchange oxygen. Tachypnea, tachycardia, anything tachy is fast. The tachypnea is an elevated heart rate. Ventilation is breathing in and out. That is one ventilation, in and out. Erythrocytes are red blood cells. And red blood cells are important because they carry oxygen around to the cells and then takes away the waste product, carbon dioxide. Okay, so erythrocytes are important for oxygen and getting rid of carbon dioxide. Now, what is an okay oxygen saturation for a child? Well, they just say greater than 90. Greater than 90, you wouldn't do any intervention. Below 90, maybe you pull on a cannula or something of the sort. But 90 is good. So, what are signs of respiratory distress? Something's wrong with your lungs, right? Something's happening. Pneumonia, bronchitis, asthma, croup. It could be all of those, but what you see, and all of those are included here. So, tachypnea, you're breathing fast. You're going to have noises in the lung, rales, water, bronchi, mucus. Wheezing is that outward, like from asthma, something irritated, bronchospasm, and wheezing. And then stridor, again, it's that inspiratory, really hard to get the air in there. So it also makes you use usually their shoulders go up. You'll see the sternocleidomastoid, your supraclavicular, this area right here will pull back really hard. It's like intercostal, but it's there. The air just, you can't get in there, and you can see them working hard. Of course, things like cyanosis, circumoral, or nail beds, that is a clue. And then, why is it mental irritability or confusion? Well, if you're in respiratory distress, the body's not getting the oxygen it needs. So your brain isn't getting oxygen, it can't think right. So that's why you're confused. So common respiratory illnesses is a sore throat. We have viral, we have strep, right? Now, the thing with strep throat, there are many serious complications that can occur if we don't treat it completely. This is why we teach our parents, make sure the child takes all their doses to the end and then follow up with a physician to make sure that that strep throat is gone. It can cause rheumatic fever. That's carditis. That's inflammation of the heart lining. glomerulonephritis, the kidneys stop working. They stop putting out urine output. So very serious. It also can cause peritonsillar abscess. And it's a surgical emergency. It's big, pussy, juicy tonsils, big fevers, and it really hurts. They go to surgery and they take out tonsils for that. And of course, then antibiotics. So another thing, strep throat, what's connected? Eustachian tubes. It goes up those little short, wide open eustachian tubes up into the middle ear. So now you've got an ear infection, otitis media, inner ear. Mastoiditis is all of the glands. It can go up into the brain because remember the brain is connected up the oropharyngeal airway. Osteomyelitis, it could go into the bones, the sinuses bones, and cause osteomyelitis there. Doesn't have to be a long bone, a toe, a finger, a leg. It could be sinuses, osteomyelitis. And then the big one is pneumonia. Strep pneumonia is very serious, requiring what to treat all these things? Long-term antibiotics, right? And that will help get rid of it. Remember children with upper respiratory infections, a child and they're breathing fast, they're losing a lot of moisture. Also, with a fever, they're losing all this insensible water loss. Make sure, because dehydration is serious in children. So if they have this breathing fast, if they have a fever, give small amounts of their favorite fluids frequently, and that will help prevent dehydration. Don't give a kid a whole glass of something. They're not going to drink it. Little small sips, you can get that into them. So bronchiolitis is another word for RSV, respiratory syncytial virus. It is a virus. For me and you, it's a common cold. But for children, 6 months is that time frame, and actually a little bit, up to 2 years. It can be something that occludes the airway. They can't eat, which means drink, swallowing, and breathe. And it's difficult because all that mucus. So bronchiolitis is a viral infection. It is actually the most important or the pathogen that you'll see with viral pneumonia. So how do we treat viral pneumonia? Symptomatic. It's a virus. We're going to antipyretics, fluids, and rest. That's it. Now, asthma is a chronic condition that affects children, and they could grow out of it or they can become adults. It is the principal cause of school absenteeism in children. It is the leading cause of ER visits. And these children, many of them are admitted. So asthma is the biggest respiratory illness that really has a lot of effects, that loss of school, needing to go to the ER and be hospitalized. Now, laryngeotracheal bronchitis, that means the larynx, the trachea, and the bronchus, is all about croup. That's all about air going in and it all gets swollen and narrowed. This is the one that we hear, that barking cough. It's croup, it's acute croup. That means really having a hard time breathing in. You're going to hear stridor because that airway's narrow, right? And that high pitched sound that's going to go in. That's also with croup. Now, if we don't treat croup, it can turn into epiglottitis. Now, the epiglottis covers the trachea so that food does not go down when we swallow. So in the case of croup, this epiglottis is swollen so much, it's covering the larynx. And it always, the biggest thing, it's called by H influenza. It is a virus, but that swelling is occluding your airway. It is a life-threatening emergency. This is the child that you'll have an airway at the bedside, either to intubate the child or we're going to have a tracheostomy tray. Sometimes they can't get through the oral passage. They've got to open the trachea to give them an airway. That's how life-threatening it is. Now, cystic fibrosis is a genetic illness, and it's twofold. It's multi-organ. It's the lungs. thick secretions that fill it up. It is also where the digestive enzymes in the small intestines do not have the ability to absorb fat. And also, this is a condition where sodium is excreted through the pores. I've told my students, if you tell a parent to lick a child, their own child, with cystic fibrosis, you would taste it really, really high in salt. So you got to replace that salt. So the diet, because of that fat's not being absorbed, so you need to give protein. You need to give carbohydrates, but you need to give sodium. You would not do low salt on these children. And because of all of that fat that's not being absorbed, this is bulky, extremely foul smelling. They're like frothy, foamy sort of stools. And men actually are, most of them are infertile because obstruction mucus in their testicles and the sperm can't get to mother. So infertility is one of the side effects. So cardiac, your heart, and your heart goes with the lungs. And there's always, just think about blood flowing and think about the garden hose that gets kinked and where does blood flow when it can't go forward. So review your blood flow through a heart. So tachy again is fast. So tachycardia is a fast heart rate. Brady is slow. That's going to be bradycardia. Dys is dysphagia. You can't eat well. It's abnormal. You can't do it right. Hypo or hypoplastic is when something's small, underdeveloped. We talk about this with the hypoplastic left heart. That left ventricle is thickened and swollen, and it doesn't work right. Now, if blood is coming down the heart in any area and there is an extra hole that blood can flow, it's going to go from high pressure to low pressure. Like from a VSD, you're going to go left side, go back to the right side. That's called a shunt. So it flows differently than normal. It goes a different way because there's an opening. So blood's going to go that way. Remember, is the sound of blood flowing through a valve and you hear, or there's going to be a hole in the heart and you could hear big, wow, wow. That's a VSD. That's a huge murmur. You can even touch the chest and feel that vibration on that sort of child. But it is blood flow. That's it's normally goes that way, but there's a reason why it's making a sound. Cyanotic is when the oxygen is low, and acyanotic, and even if there's a congenital heart defect, it's still blood is flowing and it's still getting oxygen. So there are cyanotic cardiac problems and then acyanotic, an ASD, a VSD, holes in the upper lower chamber. They're not cyanotic. They're still getting blood flow around. And then stroke volume is the amount of blood pumped with one contraction. So ASD, opening between the upper chambers, between the right and the left, and it goes from the left to the right because it always goes from strong flow to low flow. So how would I know that it's stronger on the left? Well, think about blood coming back to the heart. It goes out over the aortic arch to the body, and it gets back into that right atrium. It just makes it, right? So flow is low. If there's a hole in those upper atriums, that left upper one is getting blood coming from the lungs. And it's something that I didn't know until I worked in the cardiac intensive care. There's 4 pulmonary veins that go to that left atrium. So that flow is huge, it's big. So it will go from the left to the right. And because it goes back to the right, it goes back into the lungs again. We can treat it surgery or cath, and sometimes, like a VSD, they might even grow out of it if it's small enough. Again, it goes from the left side to the right side. Again, cardiac cath, sometimes surgery, and sometimes it goes away. It all depends on the size of that hole. Now, a patent ductus arteriosus is as simple as giving oxygen to the body. So, this is your oxygen hose. So, if everything else fails, this is that duct that will give this body oxygen. We call it fetal circulation, right? Connects the pulmonary artery to the aorta. So, lungs to the body. And it's good because it increases that oxygen to the body and it helps the heart pump, right? Now, sometimes it's open and we don't need it there and we can close it. There's a medicine called indomethacin, or we could do surgery. Sometimes do a cardiac cath and close it. It all depends on the size, etc. Now, coarctation in the aorta is a kink in the garden hose. The blood comes off the left side, goes over the aortic arch, and goes down to the body. And there is a kink, a restriction, a narrowing. Blood can't go down, okay? It just goes back up. So, what would you see? Well, this is a child when you feel the pulses at birth, the pedal pulses, the dorsalis pedia, the posterior tibial pulses. They're going to be very little bit or not at all. And that's going to give you a clue. And then you're going to do blood pressures. And we call it a four extremity blood pressure. We're measuring the upper, so that's above the kink in the aorta. Those blood pressures are going to be high. But the ones that are lower are going to be lower. Blood's not getting there. Sometimes if we don't open that kink, that restriction, that narrowing quick enough, where does blood go? It goes backwards. So it goes back through the aorta, goes back through the left side, and it fills up in the lungs. And that's why it's congestive heart failure. We diagnose that through an aortogram, which is a dye that looks at the aorta, seeing how narrow it might be, how restricted. We could do that. We figured out what it is, either surgery, or sometimes it will go to the cardiac cath. They put a balloon in it, just like they do adults when they're having a myocardial infarction. It opens up that passageway and then lets blood flow. Now, tetralogy of Fallot is when that right side, all of a sudden, that pulmonary valve, that which means blood going to the lungs, all of a sudden closes up and it's tight and it doesn't let blood go. And this is going from oxygen saturations of 100, it can go way down to 10 in like a minute. It's happened to me before. And what do we do? What's our treatment? Well, we're going to take that child and put them knee to chest. Whether they're on their back, put their knees up to their chest, on their side, hold their head, put their knees to their chest. And it basically changes the pressure in the abdominal cavity and the chest cavity. And it pops open the valve and it lets blood flow. There are four abnormalities that are with tetralogy of Fallot. We always see them. They always have a hole between the ventricles, so a ventricular septal defect. As I said, that pulmonary valve is not working good, so you see pulmonary stenosis. And then when blood can't go up there, it stretches that right ventricle. So that's why it's right ventricular hypertrophy. It stretches. The muscle's not going to work as good because all that pressure, blood can't go in, it's stretching the muscle. And then something called an overriding aorta. It just means the aorta just pushed over a little bit with it. Treatment, that's for the doing the knee to chest. I mentioned hypoplastic left heart. It just means that left ventricle is underdeveloped and there is problems getting oxygenated blood to this child. Most severe of all cyanotic congenital heart defects. It requires multiple surgeries at least 3 stages, and cardiac casts, etc., all in between. So what do we do? I've already mentioned an aortogram, something we look at the aorta to diagnose that coarctation. We're going to do an echocardiogram, looking at the way blood flows. And what do we see when there's problems with the heart and not working right, like going into congestive failure? Sudden weight gain is the big thing, where all of a sudden you're retaining all this fluid, it's building up into the lungs. And then these children, because you don't have the oxygen flowing as easily and that fluid is covering the space in the lungs, that heart's saying, let me beat faster, let me try to get oxygen around. And even at rest, they're working hard. And because of the fluid, they are going to be very, very short of breath. So complications that you might see: pneumonia, extra fluid. Okay. Remember, rheumatic fever, we're going to give penicillin. That's what we do. Remember, that's from that strep infection. And we will be given penicillin to fight that carditis, the inflammation, infection of the heart. It also causes meningitis. It can go up into the brain. Also, glomerulonephritis. Again, this is strep, and otitis media, inner ear infection. So again, strep is a big complication in the hearts. So congestive heart failure, congestion in the heart and the heart not working right, congestive heart failure. Early signs, again, congestive heart failure, that means there's a lot of fluid. The heart's having a hard time pushing against all this extra fluid. So they're trying to work really hard, trying to get oxygen to the body. So you're going to see that heart tachycardia just even at rest. And this is a child who's going to tucker out really quick and get tired and unable to eat all their food. So they're going to have fatigue. It's going to be, they're going to fall asleep eating. They're going to be sweating like they've run a mile quickly. And then they're going to be dyspneic. And the big thing, congestive heart failure, the diagnosis. And we know that absolutely is fluid, sudden weight gain. That's why we do daily weights on children with congenital heart defects. So as a nurse, what do we need to know? You have a child, the heart's not working good, you're in congestive failure. Number one, you're going to disturb them as little as possible. So you organize and do as much at one time as possible without overexerting them. You're going to, if they're crying, give them something to eat. They're expending energy crying. Give it to them because they're going to slow down anyway. So small, frequent feedings are better. A little bit of oxygen can help that dyspnea or difficulty breathing. And remember, medications are going to be given for this child. Remember, we always check these dosages, whether it's digoxin or furosemide. Always make sure that we're doing the medications on a current weight to make sure we're giving proper dosages. And anything that does with fluid, this is too much fluid in the heart and the body, and the heart is getting tired. So, what is the big nursing assessments? Recording intake, output, daily weights. Those are your big things with the nursing care. So rheumatic fever, as I said, is due to a strep infection. It also can involve the joints and the swelling, the skin. It all has to do with some movements. Chorea is called. They're not able to, their arms are not going to work the way they want them. It's their own way. And many times that brings them into the hospital or the doctor to be checked out. They determined it was due to a strep infection. So, how do you treat strep? Well, penicillin is that drug that we're going to do to eliminate a strep infection. Because if we let that strep infection go on and don't treat it, it's going to cause carditis and it's going to be permanent heart valve damage. So, we're going to make sure that not only they get that high dose antibiotic, but also they're going to do a monthly dose of antibiotic for a minimum of 5 years, we're really protecting that heart because the heart's working hard. Rest. We're going to give inflammatory drugs, steroids, aspirin. And if it's in failure, again, letting the child eat when they want. If they cry, feed them. Don't disturb them. Cluster care, it's called. A bunch of things at one time, as long as it doesn't overexert them. Now, hypertension, we don't treat with drugs. What we do is we first of all try to increase their activity a little bit, and we're going to try to change their diet. And usually that's enough. So we know that we need full fat in the diet up to 2 years old. Usually hypertension happens after that. So then we'll do the low fat milk products. Of course, increasing fruits, vegetables, fish, poultry, and of course, watching their sodium in their diet, no salt shaker, and of course, a low sodium diet. Hyperlipidemia. It is excessive fat-like substance in the blood. And we have two types. Now, this is the way I remember them. There's LDL and HDL. LDL is lousy cholesterol, and it really is clogs up the arteries, and it's not good for the body. Now, HDL, or healthy cholesterol, you can see it takes the fat, the liver, and excretes it so your body doesn't fill up in the blood with cholesterol clogging arteries. So blood disorders, anemia, most common of all childhood disorders. What is anemia? Well, it's the lack of red blood cells in the blood system. What does the blood cells, the erythrocytes, what do they carry? They carry oxygen to the body, right? And if you don't get oxygen to the body won't grow, and there's going to be growth retardation. They'll be confused, they'll be tired, they're not going to be able to be active. So, anemia, the hemoglobin gets too low. There are many types. There is by diet, and there's also some inherited, acquired. Sometimes it's that their cells are not produced the way that they should, and some are just lost, they explode, and then there's some that just die quickly. So, what blood disorders do we have? There's the whole names of them. Iron deficient anemia. We usually don't see iron deficient anemia till after 6 months, usually about that 9 to 24 months. Because what do we change in the diet? First 6 months, iron deficient, iron fortified formulas, and if we have cereals in there, of course they'd be cereals, but iron fortified formula and breast milk, they're getting all the iron that they need. We're starting to wean them off into foods, and now they're not eating all the foods and not getting all the iron that they need. We know cow's milk is not good in iron, not like that iron fortified formula or breast milk. So we will give, change the diet, but many times at this young age, they need to be given a supplement. So iron should be given between the meals, never with meals, should be before, and never with milk. We should be given it with orange juice because that's acid. The iron that we give these children is liquid, and it will be broken down by the gastric acid in your stomach, and then it starts working for the body. So we don't use milk to cover the stomach because we need that acid, and then we do the orange juice to give it a little bit more acid to help break it down. Iron-rich foods, green leafy vegetables, spinach, right? It's always Popeye. My mother used to say, you need your green leafy vegetables and be like Popeye and strong. I'm like, I don't like it. Today, I love spinach, but another story. Hemophilia is where the blood does not clot. There's a factor missing somewhere. hyperlipidemia, too much fat, or fat-like substances in the body. Now, sickle cell anemia is when those red blood cells are shaped like a sickle, like a crescent, like a C, and it can't pass through all of the capillaries in the body and it gets stuck. It's because of not enough fluid. Dehydration can cause it. So, what do we do in emergent? Well, we're going to get some oxygen on that child because whatever oxygen cells are there, we need to carry some oxygen around. And if we hydrate, we're going to dilate the vessels and get rid of that clog that's occurred. And of course, pain medicine, we always give it to them. They're usually in a lot of pain, so they need morphine or hydromorphone. I mean, they get some strong medicines. Erythropoietin, we know that is to produce red blood cells, right? So erythropoietin, um, we know we can also give that if they need more red blood cells. Thalassemia is when the body can't produce sufficient adult hemoglobin. I call them the square cells or rectangular cells. They're more not the sickle cell, they're not the round, but they burst quickly and they don't hang around long enough. So your hemoglobin hematocrits are very low. Because of them bursting so much, you're going to see cardiac failure and profound anemia. And we know that the Cooley's anemia, the worst type, is the one that's going to need blood transfusions in order to live. We know that traits come from mom. You can have some mild thalassemia, but usually what we're talking about is the Cooley's where you need blood transfusions. Now, leukemia. Leukemia is a cancer where the white blood cells are produced, but they're not the way that they should look. They don't work right. Um, some of the things that we need to teach our families and our children, if they're older, is to delay immunizations when they're in that immunosuppressive therapy. Just like if they're on steroids, you wouldn't give some live vaccines, right? With leukemia, there is no immune system. Their white blood cells is less than one. It should be somewhere about 7 is a normal one, right around there. So it's nothing. So anytime they're exposed to infections, we need to tell the doctor. With leukemia, they don't feel well, and they still need nutrition. So that's why you give food in a way that looks good, so maybe the child will eat some. We need to do good mouth care because they're going to have sores in their mouths, and you should be checking their mouths for what's going on. Infections or ulcers in the mouth, and this child with leukemia, they've got cancer and they're scared and they're getting big chemotherapies and they're in a hospital a lot. So this is one that especially children who are able to express their feelings, let them talk. Now GIGU chapter 28-29. So dis is a difficulty, phasia is difficulty swallowing. One of the most common drugs that is ingested and it's toxic, especially to the liver, is acetaminophen. So holding that medication and locking it away from children is very important. Types of GI disorders, it's either some sort of problem, a functional thing that causes fluid electrolyte imbalances, or you have some that the GI loses fluids, vomiting, diarrhea. It could be absorption problems, it could be your cystic fibrosis, celiac disease, one of those. You're just losing, all of your vitamins and your electrolytes, etc. Pyloric stenosis is when they're young kids, usually somewhere between 1 week and 3 months, and their projectile vomiting requires surgery. There is the dribble, which is just reflux. Pyloric stenosis is they will projectile across the room. Meckel diverticulum is a little outpouching or bulge. It's in the small intestines and it causes this little tissue called a diverticulum, which has a blood vessel or more in it to rip, and it causes bleeding and surgery is required. Appendicitis, extremely common, with children. And we know our biggest concern is not getting that appendix getting out soon enough so it ruptures. And if it ruptures, it's putting all of this debris into the peritoneal cavity and it causes peritonitis. And even if it's ruptured, they've got to get to surgery. You need to clean out that peritoneal cavity. It's a huge, huge infection. What do you see when we look at these children? Well, they come in complaining their tummy hurts. Right lower quadrant, they're going to be bent over, guarding it. If you push it in and push it out, rebound tenderness. It's at that McBurney's point. So, what do we look at when we look at a child with possible appendicitis? Well, you're going to do, a CBC, simple. Let's look for infection, right? We're going to look at a CRP that looks for inflammation. So we're going to do all the x-rays, ultrasound's going to show it to us. And they need to go when they figure out it is the appendix, it is ready to go, ready to burst, they need to go to the OR, okay? When they come back from the OR, we haven't lost the appendix. We're able to get it out. We are going to be monitoring their vital signs. Let's look at those lab values, that white blood cell count, making sure it's not going up. It's showing you more infection. We want it to come down. Of course, pain control is big. Cough, deep breathe, get up out of bed, let's walk, let's ambulate, and then slowly advance the diet back to normal. Hirschsprung's disease is something that usually we find at the beginning of life for an infant, and it's usually this big outpatching of the colon, usually the descending part, right before the anus. It's this area where there's no nerves. So it doesn't know how to do peristalsis. It doesn't move. Bowel movements go in there and it can't go anywhere. So it needs to either have a temporary colostomy. Sometimes they can reverse it immediately and just connect the ends, but sometimes it's a colostomy. And then usually before 1 year, they'll reconnect it because that piece of intestines doesn't work. They don't need it. Gastroenteritis, inflammation of the stomach and intestines. Why does it happen? Because of no infection. It's either a food intolerance is a big thing. Vomiting, diarrhea is a big clue when you're introducing foods that it's the food, they're not tolerating it. Overfeeding it can cause vomiting and diarrhea. Formula's not prepared correctly, or there is sorbitol in some medications, and that's why that's there, that we wouldn't want to give over their doses. And if we're giving those medications, you should question, is that too much sorbitol that we're giving? Biggest thing with losing fluids, vomiting, diarrhea is always fluid electrolyte imbalance. They're going to lose a lot of it. So it does cause severe dehydration. Now, there's a question that asks, so if you had a child admitted for severe dehydration due to gastroenteritis, and it's 3 days later, and you're about to discharge the child home. Now, yes, assessment-wise, the child's more alert, active, etc. But what is the one thing that we can say, yes, they're doing better? And that is the weight. Remember, anything with fluids, look at their weight. Intake output can show it, but your daily weights. If we see that weight going up, we know we've replaced the fluids. We know that we've been good with the dehydration. Now, celiac disease is in the small intestines, and the body does not like gluten, and it doesn't let fat be absorbed into the body. So, what is gluten and what should a child avoid? It is flour, wheat, barley, oats, and rye. One of the replacements is good is there's rice flour now that is used really good. They can have all the dairy, fruit, vegetables, protein, beans, nuts, legumes, but they can't have anything with a breading on it. Macaroni and cheese, chicken nuggets. Those are the things they can't have unless it has been floured with rice and gluten free. Hernias is when, and I like to talk about the umbilical hernia because this thing pops out and you can push it and it's soft and it should be able to go squirt in and out easy. When it cannot, it's telling you that the intestines had twisted and blood is not getting to that intestine part and it will die. So, what do we need to do? Well, because of that severe pain, tenderness, they need to go and have emergency surgery to open it up, look at the intestines, and maybe untwist it, find out why that intestines isn't getting that blood supply. Acute glomerulonephritis, again, that's your strep infection. What do you see? Remember, they're not urinating, right? That's the big thing. They get elevated blood pressures. Now, is an allergic reaction to strep? Yeah, the kidneys don't like strep. So this is the one where you see periorbital edema around the eyes. They'll be anemic, paler, high blood pressure, and it can be corrected. And how do we correct it? Strep, penicillin. Now, constipation, big thing with kids. The first thing is increase fluids. Fluids is always number one. Give them fluids and then increase the fiber, raw vegetables and fruits, not cooked, not steamed. Raw ones are better for fiber. GU problems, we know little girls sitting in a little bubble bath, these short, wide open urethras, that water from the bath can go up into their bladder and cause urinary tract infections. It's one of the big reasons of urinary tract infections. It's also that wiping front to back, trying to get that correct. And they say that increasing fluids, number one again, because now you're flushing out the system and, also making sure the child is going to the bathroom and not holding it. Also, white cotton underpants. We like the cute ones, but in the case of little girls with urinary tract infections, white cotton helps it breathe down there, and the chances are less of urinary tract. Hypospadias. In a male that's born, the urethra should open at the end of the penis. In a hypospadias, the hole's underneath somewhere on the dorsal side of the penis, okay? And they can correct it, they can make it work. Cryptorchidism is when the testicles are up in the abdominal cavity or somewhere there, one or both, all different ways. And it's just, we're watching to make sure that they come down. If not, we do surgery. Now, skin conditions in children, impetigo. Even my grandson had this. He had it behind his knee, and his mother thought he had just itched his mosquito bite too much, and it was getting goopy and oozy and spreading. And I went, "It's not mosquito bite. That's impetigo. It is contagious, and it is a staph or strep infection. It's oozy, juicy, requires oral and topical antibiotics, and that's how it was treated. Ringworm. This is a little round, little rashes. Again, it's fungal. It's going to get fungal medicine. Pediculosis, lice. It's those little bugs in the hair, right? Eczema. It's hypersensitivity skin. It's inflammation of it due to many different causes. Could be just an allergen. Fungal infections. These are a lot of the capitis, the corpus, the pedis. This is, athlete's foot. They've got these also on the scalp type thing. Again, put fungal medicines on there. Pediculosis, which is the lice. So it's not just head, it could be anywhere where there's hair. And of course, even pubic, underarm hair, wherever. Scabies. Remember scabies when we put on that Smith lotion? We have to keep it on for an extended period of time before we wash it off. Usually we put it on at bedtime and wake up in the morning and then can take a bath. Burns, remember with burns, the big thing. If they've splashed in their face, worry about airway, okay? That's your biggest one with burns. Worrying about, did it go in their mouth? If you see some little fringing around the area, think airway, airway. And there's all types: thermal, chemical, electrical, radiation. Scabies, again, this is those little bugs. They say these come from going to hotels, right? If we have one child or one person in the house with scabies, you need to check everybody. And everybody needs to have treatment because, again, you'll be spreading it from child to adult, back and forth. You need to wash all of their clothes, but you dry it in high heat. That's the big thing. If they were playing with their toys and you notice the scabies, well, those things, put them in a bag, like whether it's a Ziploc bag, garbage bag, make sure you tie it up tight, leave it for a week, and that will suffocate them and will kill them off. Again, burns, worry about the mucous membranes, always be worried about the face. And again, airways always number one when we worry about burns. The one thing, and I've seen it, where a child had burns on the buttocks and the back of his legs, quite severe. And they said they put the kid in a bathtub. Now, most parents check the bathtub before they put it in. Was that abuse? You've always got to think about that. Remember, as nurses, you're here to protect that child. Make sure that they'll be okay. Be careful with things like things hanging off of stoves, cords. Of course, we always want to make sure that they're not within reach, and that childproof should be done on all the things that can hurt them. Remember, if we have a child with burns, they're going to need extra fluids because all of that tissue's been, charred and burned. So monitoring urine, which telling you how dehydrated or not you are. Intake output, skin turgor, lab values, look at mucous membranes and daily weights. So eczema is that genetically hypersensitive skin. Now, there is a word called lichenification. And what this is how severe the eczema is. It's how thick the skin folds are from the amount of itching and from the amount of irritation to the skin. So lichenification has to do with the way the skin looks. So what is our treatment with eczema? Well, trying to relieve that itch. That's the big thing because a kid will itch, 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 and that's causing lichenification, right? Making it thicker because of that repeated scratching. Making sure we hydrate the skin, relieving inflammation, and always preventing the infection. Acne in your older children, again, it's routine skin cleaning, making sure they're not using any greasy stuff and oils around their face. Again, over washing is just as bad as not washing. So no excessive washing. There are multiple topical oral stuff that we can do. A dermatologist will give a good combination and try to see what works best for that child. And again, you need good compliance by that teenager in order to get a good result. Metabolic. Hypothyroidism, the thyroid. We know that if children don't get thyroid hormone, their cognitive growth is not going to be there. They need a thyroid hormone in order to have good mental alertness, being cognitively aware. That's the big thing there. Um, Diabetes has to do with your pancreas, has to do with metabolism of sugar. And the pancreas, doesn't work the way that it should. Now, children almost always, when we diagnose them, are type 1. That type 1 diabetes means they will never turn to a type 2. It means that they will need insulin lifelong, okay? And it needs to be monitored closely. Now, type 2, we see that maybe in the adolescents where they're overweight and we could put them on a diet, treat them, and then they might become a type 2, but that's about the only one. Now, what do you see when you see a child with a diabetes? You're going to see some symptoms. You're going to see polyphagia. I'm hungry, hungry, hungry because my body's not digesting sugar. My body doesn't know that, so it's hungry. And then it urinates a lot and drinks a lot. Polyuria, polydipsia. Because we're not eating all of the carbohydrates, they're just there, not being used. They're not getting calories. They're going to be extremely sick and they're going to lose weight and they're going to have no energy. Another telltale sign is when they urinate their bed at night, where they've been fine. They've never done it before. And it's just an all of a sudden thing that happens. Enuresis nocturia. Hypoglycemia, what do you see? Well, you don't have blood sugar or you have too much insulin. You are going to become irritable. You're going to be weak. You're going to get confused because there's no sugar in the brain telling you what to do. You're not going to think right. Your muscles aren't going to work right. And you're going to get pale and you're going to be sweaty and shaky. So, what do you do for a child with suspected hypoglycemia or insulin shock? Well, you need to do something, and it depends on patient condition. If the child is awake, complaining of feeling jittery and weak, and feeling not right, you would say, all right, the kid's telling me that kid's alert enough to have some sort of sugar. It could be a glass of milk, orange juice, or sugar cubes that they have. If the child is not alert or unconscious, we're going to give that glucagon. Now, DKA is another word for diabetic coma, diabetic ketoacidosis. It is where you have hyperglycemia, all this blood sugar, and you can't use it because your body don't produce your insulin, and your body's eating other stuff like proteins and fats, and ketones are made. So what do you see? Ketonuria, that's the byproduct of the fat and the protein. You're going to see their pH go down, go into metabolic acidosis. And because they're so full of sugar, they're oozing sugar through their pores. And you're going to smell this fruity breath. And they are not going to be as alert. They're going to be like pale and just not holding their head up. They just alter level of consciousness. Once we get fluid and the sugar down, they feel better. Now, children who are diabetic going on vacations, really important that they have extra prescriptions if needed and supplies, that there's an alert somewhere where they'll know that they're diabetic in case of problems. And wherever you're going, know where you can get, help if you need it, whether a hospital or if there's a physician that your physician knew. Cushing syndrome is when there is too much cortisol, or you've taken too much prednisone, solumedrol. It's an overproduction of adrenal hormone cortisol, or you've taken too much prednisone by mouth. And What do you see? Well, fat goes to the cheeks, it gets big, and you get this big moon face. You see also fat on the trunk, and you look big and stocky, but you have skinny, tiny, thin extremities. It's like just the midline gets bigger. And the one thing about that big face, that moon face, you'll see these big ruddy cheeks. And ruddy is like red. They become red and big and moon face. Now, diabetes mellitus has everything to do with pancreas and sugar. Diabetes insipidus is the posterior pituitary gland, and it only cares about fluid balance. So this is a child who drinks, and urinates. And that's all. They're not hungry. That is diabetes mellitus, okay? Because of all of this fluid in and out, our big concern is electrolyte imbalance. Of course, you're going to lose potassium, right? And we need to make sure that where's their heart rate? With all of this in and out of fluid, is their heart rate okay? Is their blood pressure okay? So it says vital signs. And types of immunity. Natural is you're born with it. Acquired is when you either had the disease or you had a vaccine. And active immunity is when you produce your own to some certain disease. And passive immunity is when you provide the antibody to the person, but this one really doesn't last long. They usually talk about how is it acquired. And again, that's either having it or getting the immunization. So dosage calc, there is a dosage calc format for exam 3. If you don't have it, ask your professor or send me a message and I'll send it to you. Any problems? Any questions?